Thank you very much. Good morning to my distinguished panel, my fellow speakers, and very grateful for the opportunity to be here. Thanks to the kind invitation of Asian Heart Society for this opportunity to speak at the Great World Congress. My name is Angela Koh. I work in Singapore. I am the director of the Cardiovascular Aging and Longevity Program at National Heart Center. I also sit on the American College of Cardiology Leadership Council for Geriatric Cardiology. Today's talk is very pertinent. From a global point of view, the world is aging. By the mid-2030s, the old will begin to outnumber the young. What you're seeing over here on the left is 2015, the proportions of orange, how deep the intensity of orange tells us how much of that population is aged 60 and above. As it gradually deepens in orange, it's going to be a worldwide problem. We're going to have more old than babies. So this is a huge problem, and I believe this is a universal global aging problem. What's important on this slide is two things. The first is really the sheer numbers in millions that affects societies around us, but also the tempo. So the rate at which, if you look at Central and Southern Asia from 6.1 to 13.1, that rate is going to double very quickly. Now, rate is important because healthcare systems can change and evolve over time, but when it's too rapid, like for example, how COVID-19 seized all of us suddenly, it's hard for healthcare systems to cope. So that rate in some parts of where we are right now, including where we are, which is in Southeast Asia as well as the rest of Asia, is going to be a challenge because it's rapidly aging. Now, what's the relevance of metabolomics in cardiovascular aging? This is a perspective that I would like to share, and we're still learning, and I'll be happy to hear ideas from the rest of us today. Basically, I'm going to talk about metabolomics, which is a system biology profiling tool. Why? Because it really has been growing in terms of providing prognostic value for the prediction of cardiovascular disease, and also that it seems to be growing in terms of population-based cohorts for the use of cardiovascular prevention and risk stratification. And then I'll go into a little bit more detail as to how to execute metabolomics in a real-world clinical setting later on. So for cardiovascular disease prognostication, we are guided by really a very nice paper about 14 years ago that looked at how metabolites, targeted metabolites, could actually predict worse events among patients who were studied for coronary artery disease from a registry data of patients who underwent PCI. So that was really the start, and also gave some attention to some of these metabolites in acylcarnitines as well as amino acids. But really where that strength started growing was a couple of years later, where they found that metabolites seem to also predict incident cardiovascular disease. So patients without cardiovascular disease at baseline, they were followed up, and it seems to predate that incidence of cardiovascular disease. This is one example that I'm showing in women. It is important in both men and women, but I'm showing this example in women really because when we talk about aging and postmenopausal status, a lot of systems biology is affected by hormonal status. It's never a system in silo, and this points to the ability of metabolites to really be that true phenotypic expression that goes beyond and above some of the confounding factors. What about aging? Over time, there has been a little bit more interest to build that possibility that metabolomics may be able to have a particular signature in older adults before the development of cardiovascular disease. And it's important because with aging, there tends to be a lot of risk factors that's hard to control, like hypertension, the effects of drugs. They have aging in other organs, and it's not easy. And is it possible? So this paper was interesting because these were patients who were old, who did not have overt severe cardiovascular disease. They had cardiovascular risk factors, but it seemed to show that, hey, that even accounting for chronological age, metabolomics could actually predict events. And this has been actually published in 2017 as a consideration that, perhaps metabolomics has a role in our understanding of cardiovascular health, not just cardiovascular disease, but cardiovascular health. And this is a scientific statement from the AHA. So how can we move that needle to understand this better, as we cope with aging? How can it be useful for cardiovascular aging? We know from our textbooks that there will be structural changes in the heart with chronological aging. Some of these things are, structural, functional, cellular, genetics, and also the response to stress or exercise. And as we want to promote cardiovascular prevention and towards healthy cardiovascular longevity, this is something we know, and we want to use it a little bit better. And how can we do this better? Now, for population cohorts, we tend to be somewhere not in the red, because that could be captured with registry and disease-based data, but we got to move a little bit upstream, right? More towards maybe the green. And it's useful to know that we actually have information, and we know in blue that there are certain changes that happen with aging. So how do we capitalize on this? It is possible because I've shown you earlier on that with disease, there has been insights from metabolomics that has given some idea that it is prognosticating for cardiovascular disease. If we were to use that same concept to understand cardiovascular health in aging, pair it to and correlate that to cardiovascular structure and functional changes, perhaps we'll get new insights. And new insights are important because we already do that. As a cardiovascular community, we already risk stratify patients, we improve our understanding. This is heart failure where, it's a common final pathway of aging adults, differences between somebody who is old, somebody who has heart failure, but then, stratify into whether they have preserved ejection fraction or reduced ejection fraction. And this is useful because that allows some form of a flag to tag what we understand with metabolomics before the onset of heart failure. We've looked at a targeted panel of metabolomics guided by what has been prognostically useful. And for example, we found that medium and long chain acylcarnitines and amino acids were associated with left atrial function, one of the first things to change upstream before overt heart failure. And it seems to be performing even well over and above what we know as traditional clinical risk factors, above the age, above hypertension, above diabetes. So there's a unique role for metabolites to provide that insights. And importantly, sex-based differences are always difficult to understand because even if we were to measure estrogen, it fluctuates. And any tool that can improve gender-based risk stratification is worthwhile pursuing. So we found that women, and we know that women's heart age differently from men. They have a different type of cardiovascular disease. When they are older or when they're younger, it's different. We found a panel of metabolites that were involved in fatty acid oxidation, basically, which correlates with cardiac aging in women. And as we talk about population health and prevention and maintaining healthy aging societies before the development of CVDs, as we want to prescribe meaningful behavioral change like exercise and nutrition and so forth for aging priorities, it might be important to really understand if some of these behavioral change, for example, here, whether somebody has high exercise capacity versus low exercise activity, would that make a difference in the metabolites? We do know on the left-hand side over there that obviously if you exercise more, your left atrial function will be better. But what we also found is that in tandem with an improvement or that difference in left atrial function, that the metabolites were different. And it was useful to narrow down which of those metabolites over here, and they are represented on the far right, which were adjusted for odds ratios. Those metabolites were associated with lower activity levels compared to older adults with high activity levels. So it really tells us that there's something happening over there. And if you were to target or make certain changes, those metabolites would be important to target. It is very important to know that for metabolomics, it does fluctuate. There are many possible confounding factors. However, compared to a pure genomic method which predict what may happen, metabolomics is that final pathway that combines genomics, transcriptomics, proteomics that tells us what has happened. So it is as real as it gets. It is what it is. It fluctuates, but it is a good composite phenotypic expression. And all of these over there tells us what are some of the things that we need to know behind our mind as we try to understand this. So definitely for mechanistic understanding, it's important. How can we move that a little bit more? It is possible with quantitative metabolomics, really, because the ability to quantitate is almost like, how we quantitate cholesterol, like LDL. So if we can quantitate how much change, for example, over here, the example I'm giving is left atrial function, we can also quantitate how much risk that is associated with and how much clinical change if your changes in metabolites will affect. So it's really important and really exciting for the purposes of precision medicine. These cut points are important. Right over there was what I was showing earlier on in terms of women. Women in aging are 1.6 times more likely to be frail compared to men. So it matters, important to both genders, but for women, where there is a lack of a good marker, perhaps this would be useful. But of course, to enter into practice change, we need a lot more real-world evidence and randomized trials. I think the field is growing, and there's an opportunity to do more work with that. One of the ways to move that into a bit more rigorous science really is to change. What happens when you try to change and modulate the metabolome? So this is a pilot study that we undertook to try and understand that change a little bit better and to really track the changes in metabolites in a very controlled setting. And basically what we can see is that right over there, intervention were a group of patients who underwent middle adult, older group patients who underwent a very controlled exercise intervention, and we saw really differences in how the metabolite changed for some of them and how much of that actually correlated with their improvements over the left over there in some of the aging markers of the heart, in terms of its relaxation, in terms of its stiffness, and so forth. So this is important. I would conclude to say that metabolomics has a role to play across the entire spectrum of cardiovascular health states, from disease, and then now moving into prevention, and hopefully future management. And perhaps metabolomics ought to play a bigger role in clinical practice. However, appropriate and thoughtful study designs for the future would be critical. We're doing some of this over where we are in Singapore. We've set up a cardiovascular aging and longevity program just so that we be able to study this alongside some of the interventions that we're doing, because Singapore does have a rapidly aging population. Thank you very much. 谢谢大家。